Welcome to This Week in Pulmonary and Critical Care Medicine. If you are balancing clinic, bronchoscopy, ICU rounds, and inbox overload, the goal here is simple. Distill what matters, explain what changes practice, and clarify what probably doesn't. This week, we move from pleural infection to uncontrolled asthma, and then into the right ventricle in ARDS. We begin with a randomized trial that challenges a common instinct in pleural infection, the idea that more irrigation must be better. Then we examine twin phase 3 trials evaluating triple inhaler therapy in uncontrolled asthma and ask what magnitude of benefit justifies escalation. And finally, we step back into physiology with a detailed review on right ventricular hemodynamics in ARDS, not just what to measure, but why it matters. Let's begin in the pleural space. Pleural infection is one of those conditions where small decisions accumulate. Tube position matters. Early reassessment matters. Whether you escalate or optimize matters. Published in the European Respiratory Journal in February 2026, the SCOPE trial asked a practical question. Does intrapleural saline lavage, either alone or combined with intrapleural enzyme therapy, improve outcomes compared with enzyme therapy alone? This was a two-center, randomized superiority trial including 89 patients with complicated pneumonic effusion, or empyema. 30 patients received saline lavage alone. 30 received saline followed by urokinase 100,000 units plus DNase 10 mg daily. 29 received enzyme therapy alone. The primary endpoint was duration of pleural drainage. The median drainage duration was 4 days in the saline alone group, compared with 3 days in both enzyme-containing groups. Saline alone resulted in significantly longer drainage compared with enzyme therapy, and critically, adding saline to enzyme therapy did not shorten drainage compared with enzyme therapy alone. That finding challenges an intuitive assumption. More mechanical irrigation does not necessarily translate into faster resolution. Secondary outcomes reinforce the same direction of effect. By day 5, intrapleural enzyme therapy was associated with greater radiographic reduction in effusion size compared with saline-containing strategies, with a significant interaction effect favoring enzyme therapy in larger baseline effusions. Only 2 patients required VATs, both in the combination group. 3-month mortality was low and similar across arms. So what does this mean clinically? First, saline lavage alone is inferior to enzyme therapy. That reinforces current practice in centers already using fibrinolytic DNase combinations. Second, and more importantly, adding saline lavage to optimized enzyme therapy does not appear to provide meaningful benefit. In modern pleural management, ultrasound-guided tube placement, maximal initial aspiration, daily reassessment, the marginal gain from additional saline irrigation may simply be too small to matter. The takeaway is practical. If you are already using intrapleural enzyme therapy appropriately, routine saline lavage is unlikely to shorten drainage or improve outcomes. Optimization appears to be escalation. Published in the Lancet Respiratory Medicine in February 2026, the KALOS and LOGOS trials evaluated fixed triple therapy with budesonide, glycopyrronium, and formoterol in patients aged 12 to 80 years whose asthma remained uncontrolled despite medium or high-dose ICS-LABA therapy. These were 2 large, international, randomized phase 3 trials conducted across more than 700 sites globally. A total of 8,820 participants were recruited, and 4,311 received treatment. Of those, 1,179 received the higher-dose triple therapy. The primary lung function outcomes were change in morning predose trough FEV₁ and FEV₁ area under the curve over 24 weeks. Compared with dual therapy, the higher dose triple inhaler improved trough FEV₁ by 76 milliliters with a confidence interval of 57 to 94 milliliters. For FEV₁ AUC over 3 hours, the improvement was 90 milliliters, with a confidence interval of 72 to 108 milliliters. Both results were highly statistically significant. More clinically relevant is exacerbation reduction. The annualized severe exacerbation rate was reduced by about 14% compared with dual therapy, with an incidence rate ratio of 0.86 and a p-value of 0.012. Against one of the dual comparators specifically, the reduction was closer to 18%. So what does that mean practically? Triple therapy improves lung function by roughly 70 to 90 milliliters and reduces severe exacerbations by about 15% relative. That is not transformative, but it is meaningful, especially in patients with persistent exacerbations. Adverse event rates were similar across groups, occurring in roughly 53 to 60% of participants, and no deaths were treatment-related. The key message is simple. Adding a LAMA in a fixed triple combination provides consistent, measurable benefit in uncontrolled asthma, even in patients without a recent severe exacerbation. It is incremental improvement delivered at scale. And as we shift from chronic airway disease to ARDS physiology, the theme remains the same. Small, measurable changes, when applied thoughtfully, can alter outcomes. When we manage ARDS, we tend to think in terms of oxygenation, compliance, and plateau pressures. But ARDS is not only a lung problem. Published in the American Journal of Respiratory and Critical Care Medicine in January 2026, this concise clinical review examines right ventricular hemodynamics in ARDS and how monitoring should guide management. Up to 21% of patients with ARDS demonstrate abnormal right ventricular biomechanics, and as right ventricular injury worsens, mortality increases. To understand why, we need to start with first principles. The right ventricle is a thin-walled chamber designed for low-resistance circulation. It tolerates volume well. It does not tolerate sudden increases in afterload. In ARDS, afterload rises through several mechanisms. Hypoxemia causes pulmonary vasoconstriction. Hypercapnia and acidosis amplify that vasoconstriction. Positive pressure ventilation increases transpulmonary pressure, compressing intraalveolar capillaries. Overdistension converts normally perfused regions into higher resistance zones. Each of these increases pulmonary vascular resistance. At the same time, positive pressure ventilation increases intrathoracic pressure and reduces venous return. So preload may fall while afterload rises. That combination, less filling and more resistance, is a problem for the right ventricle. Initially, the RV compensates by dilating. Stroke volume can be preserved through what the authors describe as heterometric adaptation, but this has limits. Once right ventricular limitation develops, further increases in afterload no longer result in compensation. Stroke volume falls. Septal shift impairs left ventricular filling. Cardiac output drops. Venous congestion rises. This is where monitoring becomes critical. Echocardiography gives us structure and motion. An RV to LV end diastolic area ratio above 0.6 with septal dyskinesia suggests acute cor pulmonale. TAPSE below 17 millimeters suggests impaired systolic function. But the key teaching from this review is that static numbers are not enough. Right ventricular physiology in ARDS is dynamic. It changes with PEEP. It changes with tidal volume. It changes with acid-base status. For example, increasing PEEP may recruit collapsed alveoli and reduce hypoxic vasoconstriction, lowering afterload. But excessive PEEP may overdistend alveoli and compress capillaries, increasing afterload. So the same ventilator adjustment can either help or harm the right ventricle, depending on lung recruitability. That is why the authors emphasize multimodal monitoring. Arterial waveform variation can reflect preload responsiveness, but in ARDS, it often reflects right ventricular limitation. Rising central venous pressure without increased cardiac output suggests limitation. Pulmonary artery catheter measurements can help distinguish preload from afterload effects. The deeper message is conceptual. Ventilation is not just gas exchange support, it is a cardiovascular intervention. Driving pressure, PEEP, and transpulmonary pressure all alter right ventricular loading conditions. Hypercapnia increases pulmonary vascular resistance. Aggressive fluid resuscitation may worsen venous congestion if limitation is present. Management therefore becomes a balancing act. Recruit enough lung to reduce hypoxic vasoconstriction. Avoid overdistension that increases afterload. Limit unnecessary hypercapnia. Use prone positioning to improve ventilation perfusion matching. Restrict fluids when limitation is evident. Right ventricular protection is not a separate strategy from lung protection. It is embedded within it. If we ignore the RV, we may misinterpret falling blood pressure as sepsis when it is actually afterload-induced RV failure. We may add fluids when the problem is limitation. We may increase PEEP when the ventricle cannot tolerate it. The core educational takeaway is this. In ARDS, the right ventricle is often the organ that determines whether protective ventilation succeeds or fails. Protecting the lung without protecting the right ventricle is incomplete care. And once you start viewing ventilator settings through that lens, your ICU practice changes. This week's studies share a subtle but important theme. In pleural infection, adding more intervention did not improve outcomes beyond optimized enzyme therapy. In uncontrolled asthma, triple therapy provides incremental benefit, but not a substitute for thoughtful phenotyping. And in ARDS, careful physiological monitoring reminds us that our ventilator settings shape cardiac performance. As always, these studies have limitations. Sample sizes are finite. Surrogate outcomes dominate. Reviews synthesize evolving evidence, but they move the conversation forward. If you found this helpful, consider subscribing and sharing with colleagues. The goal remains steady, practical, physiology-grounded updates for busy clinicians. Until next week, stay curious and take care of your patients.